Thank you everybody for joining today. We're going to get right into it. Today we're going to look at another aspect of charge capture, the most complicated aspect of charge capture, which is the pharmacy. There's a disclaimer statement that all of this is published at this time is current. It can change at any point in time, and we frequently know that pharmacy regs do change. Any of the CPT codes shown in here are the copyright of the American Medical Association. Any revenue codes are entirely copyrighted by the American Hospital Association, and you cannot distribute it without their express written consent. We did last time, we did the focus on supplies. So this time we're going to do on pharmacy. And one of the agenda items we're going to cover today is the charge capture process. It's entirely different for pharmacy than general charge capture. Identify points where leakage characteristically occurs, multipliers as a leading cause of reimbursement failure, and then the cost. And I think we need to just come to the conclusion that in today's day and age, the cost and the charges are one concept. So you have to start looking at what's your cost to provide, and then what's the reimbursement that's going to offset that to increase the margin, because reimbursement is fairly static and you have to capture all your charges to get that static reimbursement, but then can you do something with the cost? And then we're going to look to ensure opportunities are reconciled. We will not be covering 340B today because that could be a 7-day seminar in and of itself. So please excuse us for just popping over that one. Objectives is we're going to say why cost is relevant, understand potential loss areas such as CDM and mapping, which is, in my experience, the #1 reason we have failed charges, why multipliers matter, and then, of course, the usual JW implication. So as we go through the charge capture flow, you're going to see it's quite different than a regular charge capture. We're all the way out here. It starts with purchase and inventory NDC, and that NDC drives the rest of this program. So when we're not getting NDCs in right, or getting it right on the shelf or right in the charge master, it can lead to units of service discrepancy. Then we have to reconcile them. And then you enter the CDNUM into a data field in the pharmacy module, but that data field also then has to map to the CDM. So if you have an NDC in your actual pharmacy module that's accurate, but the CDM is not accurate, you're going to have a disparity potential in your charging. Both of these will then flow to your charge master. Now, what's different is all of this happens before the physician order occurs. In regular charge capture for supplies, whatever, the physician order occurs much earlier upstream from this. So this is all set up and ready to go before the physician order. Once a physician order happens, you dispense it, and then it comes from the charge master all the way down, and in this red triangle is the key to it all. It has to take your dispensed units from the NDC, be it milligrams, micrograms, whatever it is, milliliters, and it has to change it into a billing unit. The billing units in HCPCS, J codes, Q codes are different than the actual description in the vial. So this calculation here is an arithmetic thing done in the background. And once you put it in, it frequently just disappears. You don't see it again. And so therefore, it can lead to charge capture errors if you're not doing random audits of this. Once that charge dispensing unit goes in, the charges are compiled onto a claim. It goes to a bill scrubber. A bill scrubber is only going to check if those units of service exceed an MUE. It is not going to check if the unit should have been 20 and you've only got 1. So here you've got another opportunity where your fail safety net is only going to capture if you go over but not under. The claim then goes for reimbursement. Clearly, it's going to reimburse on the units that you provide. And so if there's a discrepancy then, we're going to look at your spend versus your dispense versus your build. And if you had 100 billable units on the shelf from way up at the top left, and you only have 30 build out, you're 70 disparate. And so therefore you need to reconcile and look at the root cause. So as you can see, this is much more complex. The other thing that's complex is these are all different modules. These are not one computer system. They may be bolt-ons, meaning they are somebody else's vendor. They can be intrinsic to the vendor itself. So for example, up here, you're using Willow for Epic. And then the CDM in the pharmacy is actually using an EAP that connects to a shell. So there's a lot of things that happen here, and there's a lot of reason for concern. The source authorities, obviously you've got Medicare and Medicaid, but the real source authority is now coming out of commercial payer guidelines. And those payer guidelines are going to specify units, are going to specify an MUE that may be different from your Medicare and Medicaid. So just because they follow Medicare doesn't mean they follow the same payer guideline. So you want to really know your contracts. Are there carve-out drugs in your contracts? If so, did you test them and what have you? So I'm going to focus on commercial today. Medicare does have, for the pharmacist, an audit toolkit. This is by the Program Integrity Group to help you ensure that you charge correctly. And so there's pharmacy self-auditing toolkit, there's a prescribing and billing toolkit, and then there's an off-label pharmaceutical thing. So this toolkit at this location really is quite helpful when you're going to audit. The other thing that they provide you is an inordinate amount of information on chemotherapy. And this is similar to your commercial payers that have a lot of payer guidelines on chemotherapeutics and complex biomoleculars. So these are your source material for your chemotherapy. If you ever have a question or you're in an audit or you got a denial, you can go back to these and look and say, okay, what did Medicare say? We also focus on Chapter 15 of the Benefit Policy Manual. This is not the claims processing, but this is the benefit policy. It says, is there a benefit at all? And that is Chapter 15, Section 50. And that describes what drugs will have a benefit under the Medicare program. And so they have to meet the definition of a biological. They cannot be self-administered. They have to meet the requirements for coverage as incident to, and that's a very important component, is they have to be incident to a physician service. So a patient that comes in and there's some sort of a visit that occurs with a nurse and they get medications from stock, that is not an incident to. So we have to look at that. Are they reasonable and necessary for the diagnosis and treatment of an injury or malformed body member? Do they meet medical practice? Are they excluded as non-covered immunizations? And have they been determined by the FDA to be less than effective? This last one is a major component of payer guidelines for commercials. They find drugs to be less than effective and therefore they're non-covered. So this section here has been expanded with your commercial payers. So it's very important to look at that one. They don't cover any drugs for Part B, which is your outpatient services that are self-administered. And we're going to go through all of that. They do cover some drugs, which are your blood clotting factors, your hemophiliac factors, and they cover them also as a special reimbursement with on the inpatient side as well. Immunosuppressive therapy, erythropoietin for dialysis, osteoporosis drugs for homebound patients. This is very important. They have to be homebound, and certain oral cancer drugs. So there's some specifics on that one. Benefit has to happen before there can be any payment. So for federal programs, a facility must achieve a benefit category, meaning they have to meet those criteria in Section 50 of the Benefit Policy Manual. However, for commercial payers, they must meet Medicare and or private payer guidelines. So they may start with Medicare guidelines and add on top of that a bit more so that you end up struggling a bit. All services have to be medically necessary. So that's a key component right then and there. Did they meet medical necessity? And if they didn't, are they going to get an ABN? All services must meet incident to. So now we're going to go in. So that's a benefit. That's what you need in order to get an actual payment of any kind or qualify for one. But now we're going to look at the other side of the coin. We know how to get reimbursement and we know that charge capture matters, but we've never really looked at the cost. And so I use a Henry Ford quote, and it's very similar to Einstein quotes and others. But if you always do what you've always done, you're always going to get what you've always got. And surprisingly enough, I thought post-pandemic we would see a lot of new evolution in charge capture. And in fact, we really haven't. So we're going to focus on that today. The 21 takeaway is charge capture strategies have to involve data and analytics, constant scrubbing, and they have to have cost as part of the review. So the per capita cost, international KPI, pharmacies contribute significantly to overall cost. And then we're going to show you that here is the United States, clear up at the top, and this is what we spend. We spend this per capita. As you can see, there's no other country even close to us. And when we look at what the 2019 adjusted, and it's always a couple years behind, we're at 10,000 per capita on actual expenditures for healthcare. But in the average country, they're 5,697. And what is the leading cause of this is prescriptions. Prescriptions in the United States by volume and by cost are significantly different than these other countries. And if I look, and I'm going to show you that we gave you the handout, but if you look at the US, we have an average cost of $466.15, and then you've got a minimum and a maximum. But if you look at the average cost out for all countries, it's $124. So we're 4 times more. If I look at the pharmaceutical spending per capita, it's $1,220 for the US and $625.73 for everybody else. And that comes from the painful pill to swallow, US versus International Prescription Drug Plan, that came out by the Ways and Means Committee in September of 2019. And it's basically organized to look at methods that the US can come up with expenditure controlling. And so if I go down here, it found that the US pays most for drugs through prices varied and 4 times higher than the average prices compared to similar country. And we could save $49 billion annually on Part D by using a drug averaging program. And those drug averaging programs are well known throughout the world. And we'll show you a picture of that right now. Got to get down. Here's the EU. Only Britain has a no reference policy going on at this time, but everybody else is using either an external reference as their main criteria or an internal reference. And that basically is they're going to take all the generic drugs and all the prescription drugs, and they're going to come up with reference points. And they're not going to pay the manufacturer any more than those reference points. And so therefore, they're controlling their cost. There are countries like New Zealand where all the prescription drugs go through the country buys it, and then they're dispensed out. Also a way to control that. That is not something that happens in America. And one of the reasons it doesn't happen here is because it would cut into the research and development costs that we have. But it is very important to see that other countries with much lower costs have this reference point. So as I go back here, I got to get back slideshow from the current slide. This 1,220 has to have some sort of application against it. Then we're looking at charge capture. The fact that the units of service might be wrong on the claim would limit your reimbursement, but your cost is still going to be high. And if you look at one of these costs, it's $16,597. We've got some hepatitis drugs that are more than that and what have you. So we want to look for units of service because your charges and your reimbursements based on your units of service of the J code, your cost will remain the same. So with more involving analytics, cost accounting, and supply chain metrics, the cost becomes a key constraint. you're going to incur the cost no matter what. So therefore, you have to make sure the charges are there to offset those costs. And many facilities participate in value-based care models or ACOs or bundled payments, where the cost, say for a joint replacement, is not only the 3 days before or 90 days after, but all the medications that go with that, and the fact you don't want them readmitted for a medication management issue. So charge is still paramount to prevent those leakages. So if we look at that, one of the leakage areas is your self-administered drugs, and that's because there's never really been a true consensus on this. We're the only country that does self-administered drugs. And they to be paid under Part A, which is hospital inpatient, all self-administered drugs are a covered benefit. They're covered. They are not covered as an outpatient Part B, and even though they're not determined to be SAD, then the medications that are not integral to procedure and not SAD can be covered, but those are integral to a procedure, and we'll talk about that. They're billed as supplies and they're packaged, and the SADs are also a patient liability. So we've got three different things going on within Part B. You've got the coverage that you had in Part A for those that are not integral and not SAD. You've got coverage but no additional reimbursement or package reimbursement for integral to a procedure, and then you have no coverage, patient liability for the SAD. The service or medication must be medically necessary. So we look at the benefit policy manual again. We have the fourth bullet down, and the second bullet is they cannot be self-administered. And again, here's 50.3, where the incident 2 requirements also state they cannot be self-administered. So what is self-administered? Self-administered is a concept that is confused by all patients. Patients believe that means that they couldn't take it themselves. So the usual thing the finance department or patient accounting here is, I was in the ER and the nurse gave me the pill. Why isn't, I was in the ER and the nurse gave me the pill, why isn't it covered? I didn't take it myself, the nurse gave it to me. What is also a similar theory to this one? Observation. Observation, I was in a bed, I thought I was covered. So these types of confusing statements occur especially in the pharmaceutical area. Medicare does put out a number of bulletins that say they're not self-administered and describe them, but most hospitals do a very poor job at describing before the patient leaves that they're going to get a bill that includes self-administered medication. So what is a self-administered? It has to be able to be taken by 50% of the, greater than 50% of the Medicare beneficiary by themselves, okay? So think of that age group, and will they be able to do it themselves? Absent contrary to the evidence to the contrary, IV drugs are not self-administered. Well, clearly they can't take it by themselves. Absent evidence to the contrary, delivered intramuscularly are not self-administered. So that's what I call using the long needle versus the short needle. When you use the short needle or sub-Q, they are self-administered, meaning they can do that. So a Lovenox or something like for migraine medicine, they are self-administered because they have the short needle. So I always train nurses to understand, did you have a long needle on that or put it in IV? If so, it's going to be covered. If you give that to them in an oral, an inhalation, a rectal, a topical, sub-Q, intradermal, they're all self-administered. So what's also self-administered? You've got your aerosols for respiratory treatment. You've got your topicals. So there's a large list of these. So only injectable drugs are eligible for service. And the Medicare contractor comes up with a list of those that are kind of borderline, and they come up with two conditions. One is this an acute condition? Is this something that just came on, or is it a type of condition like migraines where it's likely to be long-term? If it's something that just came on, it's likely to not be self-administered. But if it's something that's just long-term, then it's likely to be self-administered. So the length of duration of the illness in the Medicare population, not the patient, but the Medicare population determines that. Also, how frequently are they going to have to administer it? So a short-term acute what uses it the long-term acute that frequency is frequent, then the patient should learn to do it themselves and they'll be self-administered. If it's like a one-off thing, then it might not be self-administered. And it's up to the contractor to determine that. So we're going to have some disparities on those lists. The other thing is the second category that we talked about was, is it integral? Is it really a supply item? So if something is so integral to a procedure that the procedure cannot be performed safely without it, then it's going to be a bundled component of that procedure and included within the APC payment. So it is covered as a supply, so that self-administered drug may now be covered as a supply, but there's no separate reimbursement. And for that, you use revenue code 250, and that packages that revenue center. So they're considered integral supplies. And some of those that CMS has come up with are sedative administered to a patient in the pre-op area, mydriatic drops that they use for cataracts, barium or low osmolar contrast provided integral diagnostic imaging procedure, topical solutions such as photodynamic therapy furnished, antibiotic ointments such as bacitracin. So let's just even talk and focus on bacitracin. Let the self-administered and the supply become even more convoluted. If the bacitracin is given as part of something that's a homegoing thing, then it's going to be self-administered. But if it's part of the completion of a procedure, meaning it's just happened, then it's going to be a supply. Now, how in the world do you bill for that? You have to default. It's either one or the other. You can't figure out every single time. So this does have issues with it. The other thing is medical necessity, and this is where the commercial payers differ in self-administered drugs. Many commercial payers do pay for self-administered drugs because they consider them to be medically necessary. Other commercials follow Medicare and they use the same list. So it's very important you know what your contracts say. Medical necessity has to be provided prior to the provision of the service. So since these are self-administered, are statutorily excluded, you don't have to give an ABN for them. But Medicare recommends that you give a voluntary ABN that says, look, these are self-administered drugs and Medicare doesn't pay for them. And this is for information only. So you don't have to give the ABM because they're statutorily excluded. But for purposes of education, Medicare recommends that you do. And I've given you the citation for that. The commercial payers, however, don't use that concept. They use a concept of authorization. And that remember, Medicare doesn't do authorizations. They are retrospective. They look backwards in audit and denial. Commercial payers are prospective. So they're going to say, is it covered beforehand or it's not? And so when you have a commercial payer, you need to be focused not on the ABN or the SAD. You need to be focused on whether that drug is covered. And they have a payer coverage list, which needs to be in your pharmacy and it needs to be in your patient access module. And some of the sites of service, especially the chemo infusion center, like, okay, do I have an authorization for this drug? If I do, on what date was it authorized and what's the start and stop time of that authorization? Is it for 1 day? Because if it's only for that 1 day and you do it the next day, you don't have an auth. So is it for the date of service or is it for a time period? If it's for a time period, they're going to tell you how many treatments or how many administrations you're allowed to do. Physician authorization number that the physician gets for their services generally does not contain the authorization for the drug because the physician isn't providing it. So I see hospitals all the time using the physician auth number, and it's not an authorization for the drug. So here becomes the next quandary. Who does the authorizations? In most places today, in integrated delivery networks, the bigger system, the pharmacy is doing their own authorizations because it represents their revenue. So we see them not leaving it to the patient access group that is not as equipped in the drugs and their interaction. A lot of times these authorizations take, take some time to do because you have to describe to the medical director something why it's being used and why it's not off label. So we're seeing more and more that the authorizations are coming from the pharmacy. Just because they were arrived at by the pharmacy, the delivering department has the obligation to make sure that that auth is present prior to the delivery of the drug. So this is where our first leakage occurs. I cannot tell you the number of times I have seen outdated auths and somebody gets a medication, said it was auth, yes, but the auth is outdated. So the delivering department is that check and balance to know your authorization. Many inpatient administrations also require prior auth. So what we usually get with inpatient is, oh, it's an inpatient stay, it's authorized as an inpatient stay. Well, that's fine and dandy, but some of your drugs are not. So you need to know who's going to do that. Is that going to be pharmacy again? Is that going to be care management? Who's going to do that? So these authorizations become a very big deal. For Medicare, there is no such thing. So it's not, well, there's a little bit of one, but it's not widespread. But for where your big dollars are coming, your commercials and your commercial carve-outs, and they don't get the attention that they need. And so we're starting to see pharmacy step up the plate and say, we're going to do it because we just are not getting the results we need from other departments. Let's talk about the multiple modules and what problems that causes. Now, pharmacy, as we showed you before in that Visio flow, it connects to a lot of things. And those modules may be bolt on by a separate vendor, such as VitalWare or somebody else, or they could be integrated, such as Epic. But generally, there is a physician order entry module. There is a 340B virtual inventory that is contained within a pharmacy module. There's the pharmacy module itself. There's pharmacy dispensing, and that may or may not be an add-on. It could be integrated with the system, or it can be an add-on with the MAR and dispensing cabinet. So you Pyxis and what have you. So that's why that one's kind of pulled outside, because you've got a second component that you've got to map into pharmacy are these Pyxis or other pharmacy dispensing cabinets, and then the MAR. So I don't know how many nurses on the line today, when you've gone to give a medication, the physician told you verbally to do it, but the physician hasn't put the order in. You pull it out of the cabinet, but there's nothing in the MAR yet. So that kind of prevents you from doing it. So this is one of those checks and balances. The nursing administration in the EMR for your start and stop times for infusions, they're generally not in the MAR. So that's another component. And then your billing module. As you see, the billing module is last. And anything that happens that goes off the rail or isn't quite accurate before that in one of these other modules will ensure that your bill does not come out correctly. So all these modules have to be mapped together and they have to be tested. And IT tends to do the mapping. The problem with that is IT doesn't necessarily know anything other than how the system maps, but may not know that they've mapped an aspirin to a Zofran or something like that, and that has the proper units because there's this mathematical calculation. So you're going to want to look and see all these things, and I always diagram them out. With a new drug that comes into the pharmacy and there's going to be a CDM, I map it out. I actually make a Visio of that drug and how it's going to go. Now, part of the confusion here is different vendors, Meditech, Cerner, CPSI, Epic, they all have different ways of doing it. And so Epic doesn't map one-to-one between a pharmaceutical and a billing module. Rather, it uses a shell technique where it puts like and kind together. And here's an example of something that went awry. I actually had a client that inadvertently put it into 250, a very, very high cost carve out drug. As the 250 went, that was a 250 without J-code shell. And so no J-code, even though there was one that it could have been used, no J-code came over. And so they missed about $1.4 million in 6 months' time of that drug because it went into the wrong shell. Many people create 636 shells now, 636 with and 636 without J-code or chemo. It depends on how your pharmacy wants to set it up. So that shell poses a connectivity concern, but it is all within the Epic module. Meditech uses a methodology between their PHA module and their bar billing module. However, that's a one-to-one. So one NDC number equals one drug equals one CDM line equals one bill line with the billing unit. So it's all one-to-one. It's none of that combined like in kind, it's one-to-one. So if in fact Meditech never updates the NDC and the actual amount in the vial changes, you're not going to get the proper outcome. Other vendors do a combination of one-to-one or a shell-like concept. So whatever it is, this is where I find the money. I always find the money in these connections. If I'm going to go and I promise the client I'm going to find you $1 million, then where am I going to go to look for the million? I'm going to look in the mapping and the units of service. The multiplier is your units of service on the bill. And as we've previously discussed, that multiplier takes a billing dosage, ordered, dispensed, documented billing dosage, and converts it into a billable dose, meaning your dispensed dosage is not what you bill. The dispensed dosage then is calculated over into a J code, and those J codes could say per 1 milliliter, and there's 4 in the vial, or what have you. So it's the step one is what did the physician order? And you look at the amount of medication they ordered. Step 2, confirm the NDC that was used to create the dispensed dose. This confirmation will need to be made by the pharmacy system, and the NDC are frequently outdated. So what we see is the NDC on the claim is supposed to be the NDC on the vial or package that you provided to the patient. That's clearly specified in Medicaid. However, what we see is the NDC is scanned in to these pharmacy modules such as Willow, but that never comes over. That NDC is not updated in the CDM. That's more of a manual task. So we have that first disparity right there. So what is an NDC? An NDC is a 10 or 11 digits. They became 11 digits due to HIPAA. The first 5 digits are the labeler, the 4 are the product, and 2 are the size of the package. So you can have the first 9 digits be totally fine, and the last 2 digits to determine the size of the package be off, and it's a whole different drug for billing purposes. The NDC determines the package size from which to convert the dispense. So you're going to need the NDC in the pharmacy module, and you have to then check to make sure that's the NDC in the CDM and then convert it. So notice I said 2 steps. Find the NDC in the pharmacy module and the NDC on the CDM. A lot of times the NDC is what is scanned on the barcode. When the nurse administers the medication, they're going to scan the patient, they're going to scan the drug, they're going to scan the order, and then they're going to scan their badge and usually scan the patient again. And so that scanning reconciles real time if that's the right drug, the right dose on the right patient. This scanning method has drastically decreased the number of risk events that occurred from giving the patient the wrong dose or the wrong drug. So it's very important that that scanning goes on, and most MARs will not let you do it unless the scanning happens. But that NDC then can be compared at two places. If the NDC on the vial doesn't match the NDC that was dispensed, we've got an issue. Then the multiplier becomes the lost revenue. So you're going to use that NDC to convert it to the smallest mathematical unit. Okay, so one drug may come in 50 milliliter vials, 100 milliliter vials, or 500. You have to pick the vial that most closely approximates the dose you want to give. So this is another issue with some of the commercials. If you ordered up 5 vials of 100 milligrams to give 450 milligrams that were ordered, and those 5 vials combined are more than the 500 milligram one, you're likely to either not get paid or you're going to get a reduced payment. So you have to understand they want you to use the largest available. Now, we have back orders and we've got all these things, so there's always this struggle. Then we take the dosage dispensed from the pharmacy over the HCPCS billing unit, and that's going to give us the multiplier we want on the claim. It's that multiplier that goes in the units of service in field locator 44 with the HCPCS code. So here's an actual example. We've got a brand of rituximab, and it's applied in 100 and 500 milligram vials. On the pharmacy module, the vial would be created, scanned as it comes in order for 420 milligrams, and please note that I made these up for illustration purposes only, was created. Then the pharmacy would order 1 vial of 500. They wouldn't use 5 vials of 100. They use 1 vial of 500 because that's the closest available amount. The pharmacy would then dispense 42 cc's of the 550 cc vial and waste 8. Now, at this point, we need to know, is this a single dose vial or a multiple dose vial? Because wastage does not apply to multiple dose vials. So we're going to say that this was a single dose vial and that 420 was ordered. We pulled out 42 cc's and we wasted 8. So what does this look like on the claim? We're going to have Q5119 JA for the IV administered, and then 42 units, and then you're going to have your wastage line of 8 milligrams, okay, at the 8 unit. So for your wastage, you're going to have actually created the whole vial, but you're going to have it on 2 separate lines. And these are all done in the background. So they pose a real threat to appropriate charge capture because they're seldom tested. And more pharmacy and rev cycles are actually having what they call a work day, where they go through their high-cost drugs, they review claims, and they make sure that what's dispensed accurately converted to what ended up on the bill. Now, the other thing I see a lot of times is, well, I made a new combination. I mixed these two things together, and so therefore I'm going to bill for the new thing. Well, that's not correct. If in fact you are simply mixing 2 components of a product which have HCPCS codes, you want to go ahead and bill them both. For example, you have 1,000 of saline and you've got 40 of potassium. Those should come through on the bill as 2 different charges, the saline and the potassium, even though they're in one bag. Dobutamine, dopamine, they have the base solution and they have the drug. These are admixtures, okay? These are not new compounds. If it makes a brand new product, you actually compounded it, then you're using an appropriate unlisted code of J999 or J3490. Notice that these J codes are for compounding. You should not use the C code, which is an unclassified drug or biological, solely reserved for new drugs after 2004. So if it's a brand new drug after 2004, you can get away with C9399. If, however, it's not a new drug and it's known to people before then, use the J code. And if you're just mixing the two together, let's go ahead and make sure you have the two charge lines. And this is something I frequently see is where they're not mixing, they're not getting two charge lines. So how do we bill for wastage? Well, first of all, I'm going to give you two examples. The first example is medications that were pulled out but never administered, okay? They were dispensed but never administered. And unfortunately, according to Novitas billing guidelines and Chapter 17 of the claims processing, if no amount of the drug was administered to the patient, then no claim should be submitted. So that's the first question I always get. Can I give, if I never gave the patient the drug, can I bill it? And the usual answer is that Medicare says no. However, I want to go back to your commercial contracts. A lot of your commercials will say, okay, if it was dispensed in the aid of a patient's care and never administered, we're going to cover it. So especially your percentage charges. Although I know a lot of percentage charge field auditors that will go through line by line by line and say, okay, I have an order for it, but it was never administered. I'm taking it off the claim. And that'll bring your percentage charge down. So this is something you need to know what you're doing with that. There should be a policy and procedure for drugs never administered so that everybody's on the same path. The second one is if I have I have a drug, not self-administered, I have a drug that is a single dose vial, meaning it actually says in the FDA, it's a single dose vial. And we at VitalWare have the pharmacy module and it tells us which drugs are single dose vial by the NDC code. And we're able to know about the wastage. Other vendors do the same thing. But you must document the discarded drug. So that's a problem with the MAR. The MAR will document what was given, and that's the intent of the medication administration record. It doesn't document what was wasted. So then you're over to another system, usually the nursing notes, where you have to report the wastage. So this is another charge capture opportunity, is to find out, is there a way for me to automatically charge the wastage at the time of dispensing, as long as the MAR does it? So it's a combination charge. Some vendors can do that, some vendors cannot, but this is a big area where it has to be documented. If you're a Medicare auditor or a commercial claims auditor, you're going to look for that and see if it was documented as wasted and how was it wasted. It's not a big deal if it was wasted in a Pyxis system, because you usually have the wastage recorded by 2 nurses. So again, this is only applicable to single dose vials. If you use a single dose vial for multiple patients, that's on you. You cannot really do the wastage if you are actually using it in a way that it was not intended. And one of those that comes up a lot of times, I get the question, is Botox. I'm using 100 milligram bottle for 5 patients. Well, good on you. Charge what you used. Don't charge wastage. So you would charge what you used. For like way in the back, there was Amgen that was putting extra in the vial to compensate for the bubble you get in the syringe for their dialysis patients. And the end result was the government came back and said, well, you cannot bill for that overfill. So there's a lot of things that go on with this single dose vial. You can't bill overfill, and you can't bill if you didn't deliver it. So what are these interventions that are going to help us? First of all, cost. We want to make sure that we're buying from a cost representative. The charge still occurs. So if we've got a high cost drug and we have a charge that's less than the high cost drug, that's our first consideration. Daily reconciliation of drugs dispensed and drugs administered is an important report to get out of your system. So what was it dispensed by patient and what was administered by patient, and spot those irregularities. Here's an example of a system that goes ahead and calculates your wastage for it. So you would put the Q5199 for that rituximab brand name. And you say, I gave 420 milligrams, I wasted 80, and it comes in one vial. And then it's going to figure out what your actual wastage is. You're going to bill 42 units, and you're going to have the second line with JW as 8. It will not do this if it is a multi-dose vial. So that's another important with these calculators, is you will not get a wastage if it's multi-dose. You only get it for single dose. So we're seeing more and more auditors and rev cycle people using this type of solution to be able to get it right. Also, charge capture software is so therapeutic that now it's comparing therapeutic billing ranges. So for example, did I put a unit of 1 on a drug that requires 40 units to be therapeutic? Using the 837 or your daily UBO4, charges go through the processing scrubber, and units more or less than expected can be identified with this type of therapeutic review. Now, a charge scrubber is only going to look at your MUEs. This is going to look at under and over therapeutic range. So here's some examples of rules. Happen to be in the VitalWare system, the charge below therapeutic dosage, and they have hundreds and hundreds and hundreds and hundreds of these, where they've gone through and they've gotten the FDA recommended dosage, not only for the adults, but some are weight-based and some are age-based. So on the next thing, we'll see the edit that goes on, and it's using that Q5119 again, and it says that you should never see anything below 38 units. Otherwise, it's subtherapeutic. And if you do, stop it. Let's review it. And that should happen, 38 units or more should only happen if the patient is 17 years, greater than 17 years of age. So only pull that where the age is an adult. Don't pull it for pediatrics. And then we have geriatric, weight-based, and things like that. So here's another example of how software is coming into play to cut this charge capture loss and ensure those billing units are correct. So in summation, this is the biggest cost to your system. It has to be managed well. The revenue integrity team, I see revenue integrity team and pharmacy, frequently they're two teams and they don't interact. So a lot of times I'll see pharmacy has their team and it doesn't interact with the regular revenue integrity team. They have theirs, and I'll hear when I go, I'll say, well, this CDM's wrong. We'll talk to pharmacy. They manage that. That's not a good idea. You need to get rid of the silos when it's this type of money involved. You need to have regular interaction where either the person is a member of the revenue cycle team or you have some sort of voice on both teams in a concerted effort to manage cost and charge. It's extremely convoluted. Therefore, you're going to need pharmacy. You're going to need the revenue cycle with the billing unit, and you're going to need IT to sit down and systematically review these items. I always start with any J code that shows up on a claim with a unit of 1. That's a quick check. So I do a J code with it's a G or K status with a unit of 1. That is a quick check that it may be that you need more units. The other thing is I can do a revenue and usage, and if I'm seeing the usage be 1 all the time for the drug that should be 20, I have a rebilling opportunity. And so we want to look at that. These charge capture things are age, weight, multiple other factors based now, and it requires review daily of all these charges or it gets away from you. If you wait 180 days, you may be too late. Now remember, the shelf life for working purposes is that those drugs should have cleared the shelf in 60 days for reconciliation purposes. And you can do quick back of napkin calculations that way. And this represents an opportunity for revenue either in the cost containment or the charge capture for almost any facility. So with that, I think we have some time for some questions. And guidance, changes.
You want me to read them out to you, Bill?
Yeah, I'm looking at the first one, the JA and the JB modifiers. I'll have to go get that for you. So please send Marie your email so that I can get that for you. The second one, reporting for waste, does this include wasted product during pharmacy prep? If it's a single dose vial and it is wasted during the preparation and it is documented as wasted, and then the MAR shows what was delivered, I believe that you could do that. You absolutely cannot do it with wastage from overfill, and you cannot, it looks like a bunch of people, the anonymous attendees want this. So we'll have to find it and then put it on our website. But that you can do that. It doesn't have to be at the time of administration, but you do have to document it and why it was wasted. Okay, so usually I see we obtained the smallest available vial and 500 in the patient's doses, and it's just like this one-liner that the pharmacy is able to put into the EMR for a wastage thing. It's in a template in Epic you can make, and it's just a wastage thing. So yes, you can. It looks like this JA and JB is a big thing. Let's see, in the chat. How do we determine a working list of drugs to look at? Well, I mean, I would start with your G and K status drugs. Those are your ones that that pay separately, and they pay according to contractor pricing. So I wouldn't start with your N status package drugs. I'd start with that. Because these are your biggest opportunity. I would look at your chemos. I would look at infusion center drugs, things that go to the infusion center. I mean, most of the high dollar stuff doesn't go to the ER unless it's a clot buster of some kind, like an Altaplace or you know, one of those. But generally, no. What billing unit should be set up for the following drug? All right, so the C9077 is a combination drug. So you would use the primary drug for your billing units. So generally the order is written for either Septigavir or, I'm going to slaughter this, Rilprovine. So one or the other. It's generally done that. Or the actual dosage is a brand name, and then you use the brand name's NDC and come up with it that way. So these combination drugs are difficult for what? If you need me to calculate that, then Anna, you're going to need to send an email to Marie for us to calculate it and try to show you.
Yeah, and just a quick note to everyone, it helps a lot if you type your questions into the Q&A panel and not the chat, because if we don't get to them, the chat panel will not record your questions, only the question and answer panel. So just a quick note on that.
And Tom, you're right. JA and JB is only for IV, and it's not usually required for commercial payers or sub-Q. It's not usually required for your actual commercial payers. Medicaid's big on it, and the 340B indicator, what have you. So let's go ahead and do Tom's also. Well, that's a JA and JB. We're going to do that. So I guess pharmacy brings a lot of the combination projects. Suzanne wants to know the combination for COVID, the monoclonals. All right, so this is going to have its own, it has its own medical necessity and transmittal on this, on how to bill it. You have to follow the specific indications on those transmittal. The individual products sometimes are not covered, but the combo is. So for this one, Suzanne, you need to know exactly what that transmittal is saying. So you look up the drug and the transmittal. I would go to your MAC website and put in the name of the drug, and up will come the transmittal and any guidance they have. The other place to look for this, I look all the time, is on cms.gov/N as in Nancy, C as in Charlie, D as in dog, NCD, and you'll see a lot of that too. If they have an M code and you're told to use the M code, then you'll have to use that as well. Now, will the payer sometimes reject the M code? If their edits, and we found this at a lot of MACs, if their edits were not set up for an M code yet, it's going to reject. When you work with your commercial payer or your Medicare contractor, a lot of times they're going to tell you to hold the claim until a specific date, and then they're going to reprocess them all. Sometimes they tell you to send it in with the M code, get the rejection, and they'll reprocess it. But we found a lot of problems with the M codes because these are not codes generally accepted by Medicare, and therefore they had to adapt the edits both nationally and at the MAC level. So if you get rejected, those are great questions, Suzanne. If they get rejected, then definitely look and see. COVID in and of itself has a litany of different guidances. And so what we have with most compliance departments or revenue cycle is they're pulling the COVID for the immunization, they're pulling it in for the combination drugs, they're making policies and procedures on it, and they're making sure that everybody follows the same pathway. In Epic, I have seen actual templates made up, where the latest guidance is into a template so that when it's ordered, that template comes up. Nursing has to make sure all their items are done. The physician has to do theirs, and then pharmacy does theirs. So I've seen this quite a bit where there are multiple requirements for a drug for COVID that have to be met before you give it. So COVID could have also been a specific indicator. We're doing COVID charge capture next month. So I'm going to add, thank you very much, Suzanne and Anna and everyone else, Tom. We're going to add some of this to next month's COVID discussion on charge capture because that's an ugly one as well. What other questions do we have? Oh, I have 14 in the Q&A now.
Yeah, there's a lot coming into the Q&A. We only have one more minute. So we can answer these questions after the webinar and send them out or post them to the website as well. But
okay, so Jackie writes, you stated you can't charge for something that's not given. If you start the infusion and the infusion actually has the drug in, then you charge the rest as what was given and then the wastage. So you can bill for that. If you never start the infusion, you cannot bill for that. Okay, so if it's in the patient, it started, then it's just like an OR procedure canceled afterwards. Maybe you find out that it's a chemo drug and they don't have white cells or something, you stop it, so that's it. What's the easiest way to figure out NDC units? I have prophy clinics that use Meditech. They do not drop an order. I have everything manually in the billing module. The NDC units actually are best found at the FDA website, where it tells you the package size. The other thing is if you work with the pharmacy that you're getting, if you're working with the pharmacy that's obtaining it, it will tell you the package size and your unit. So that is a great question. The items discussed be sent following this, yes. How should pharmacies submit the request to ChargeMaster for building CDMs into system? Meaning some clients submit a dose size, other a vial. Somehow they're administering, others are HCPCS. I'll tell you, honestly, Kia, if you don't work solely from the NDC, it's going to be a nightmare. You start with the NDC, you track it all the way through the pharmacy system, you make sure that the CDM is set up for the lowest chargeable unit. And that's key. The lowest dispense unit, the lowest chargeable unit. Don't do it by the vial or whatever, because like a Dancitron, a simple one that's given every day, there's 4 units and 2 cc's. And if they only give 1 unit, you know, you've got only 1 coming on the bill. So I say the NDC is the best way to do it. And then the multipliers off of that. What billing unit should be used? Yeah.
I hate to cut you off, but we're at time right now. So I think we're going to have to answer these post-webinar and post them to the website.
Okay.
Just because we have to we have to stop with.
I'll be answering these until I'm 100. Okay,
Yep.
thank you all very much for attending today. Thought we'd have more time for Q&A, but we'll get these out to you. Marie,
Yep,
what are you going to do? Are you going to send it out, or are you going to just put it on the website for them to access?
I will be posting it on the website for everyone to access once Bill gets the answers to these questions. We'll get them recorded and post them to the website.
And you get CEUs too.
Yep.
Thank you so much, guys. You have a great afternoon.
Yep. Thank you, everyone.
Bye-bye.